Hello, and thank you very much to Lupus Hub for the opportunity of this interview taking place in the beautiful city of Hyderabad in India, where I am for the Indian Rheumatology Association meeting. So it's been an amazing event with 1,500 rheumatologists from all across the country, and I'm very privileged to be here. My name is Laurent Arnaud. I'm a professor of rheumatology working in Strasbourg in France, and I'm also the current president of the European Lupus Society. I'd like to discuss a little bit about what I think are the most important challenges in the context of lupus. And I think some concepts are really rising these last years. I think we know, and it's been known for quite a long time, that lupus patients accrue damage with time. But I think it is more and more recognized that damage can be really early in the context of lupus, especially in the first month. And this can be due to uncontrolled disease activity, but also to side effects of treatments and corticosteroids. And we all know that we are using too much corticosteroids in lupus because this drug works really well. It really relieves the symptoms, so the general practitioners usually prescribe important amounts of corticosteroids, and even the patients usually have access to small batches of corticosteroids that they take in sometimes an uncontrolled manner. So I think we really have a big challenge around corticosteroids. And I think it really pairs with this new concept of treat to target and disease modification. And the question we're really asking here is there an opportunity for an early intervention, maybe targeting strongly at the beginning of the disease lupus in order to improve the later outcomes? And I think the answer is yes, actually. There are lots of publications, lots of talks, and it was the case here at IRACON about treat to target in lupus. But I think it's really challenging because we will all agree that we have one target, which is remission. But I think what is a bit more controversial is to define remission in the context of lupus. Treat to target is something that is not new. It's coming from the field of diabetes and cardiovascular medicine. It has already been applied in the context of rheumatology. I'm thinking rheumatoid arthritis, I'm thinking spondyloarthritis or gout, but it is a bit more novel in the context of lupus. And I belong to this group called DORIS. We've been meeting every year for 5 years, and we have proposed a definition of remission, which is now known as the DORIS definition of remission. And I think it's a great instrument, and it's been studied across prospective studies, retrospective study, even in randomized controlled trials. And I think it's a meaningful instrument or meaningful outcome, but I think it's really difficult to translate into day-to-day clinical practice. So I'm feeling very privileged because I'm leading an international task force about treat to target in lupus. And what we are really trying to achieve is to understand how we can apply this context and concepts of treat to target and disease modification to the real world, the practice of lupus. I think what we would like to achieve is no clinical disease activity. And in the context of lupus, no clinical disease activity means no clinical manifestations of active lupus and also normal routine lab results. I'm not talking about the lupus serology, the antibodies, the complement. I'm just talking about something that is very basic, very achievable in real life. So no clinical manifestations and normalized routine lab results. And that is not enough to define remission in lupus, because you can have that with 60 milligrams of prednisone, and that cannot be called remission. We want to have no clinical disease activity and a very limited amount of prednisone. And most people, most experts agree that the threshold for toxicity of corticosteroids is around 5 milligrams per day. So our definition of remission is no clinical disease activity and no more than 5 milligrams of corticosteroids, prednisone equivalent on a long-term basis. But of course, I believe that we should try to stop corticosteroids in a huge majority of lupus patients. So this concept is actually applicable in systemic lupus, but we all know that we need a plan B. This plan A cannot be obtained in 100% of patients, especially if we're talking remission without treatment. So we need the plan B, and the plan B that is the most heard about is the low disease activity state, LLDAS, which I think is really an amazing index, an amazing instrument. Patients reaching LLDAS have much improved outcome compared to patients not reaching LLDAS. Yet the LLDAS enables corticosteroid dose is up to 7.5 milligrams per day of prednisone equivalent, which I believe is a bit too much. So for me, really, the LLDAS is a plan B. So everything in lupus is now, can we modify early disease thresholds or disease activity to reach this target as soon as possible? And I think the answer is yes, because we have more and more new treatments. Just the last few years, belimumab, which was already approved in the context of lupus, is now approved for lupus nephritis. We have an approval for voclosporin. We have an approval for anifrolumab. And I think this is going to improve the way we take care of the patients. But I want to say that developing new drugs is really complicated in the context of lupus. We have 25 drugs that reached phase 2 or phase 3 clinical development and failed. But despite this, we have these new approvals and more are coming. We recently reviewed the full pipeline of clinical drug development in lupus, and I'm a bit challenged and puzzled to say that we have 92 drugs in clinical development and more than 15 phase 2 trials. So my hope is that at least some of these drugs will be going through and that we can apply them to our patients. But talking about new drugs is great, but I think we should already improve the drugs that we have. So I already mentioned corticosteroids, using them wisely, not too much, but maybe not too little. I think we are really lacking good studies to define the proper doses that we should use in the context of lupus based on precise organ involvement. I think we should optimize hydroxychloroquine. Everybody knows that all lupus patients should be treated with hydroxychloroquine. But when we look at the numbers, it's very surprising because in most cohorts, in most trials, around 70 to 80% of patients are treated with hydroxychloroquine. So where are these 20% of patients going? Why do they not receive hydroxychloroquine? And we also know that lupus is a chronic disease, so therapeutic adherence to the drugs and hydroxychloroquine is something important. And then, of course, we have all the immunosuppressive agents, conventional immunosuppressive agents that we've had for many years. And one question about biologics is, shall we use them on top of these immunosuppressive background, or shall we use them early? And well, I think this is an interesting question. I'm convinced that we should gather more data before recommending an early use of biologic, despite the fact that this is a very interesting concept. So with this, I would like to thank you very much. It was, for me, an amazing opportunity to be here in Hyderabad at IRACON 2023. And I would like to say thank you again to Lupus Hub for the very kind invitation to give this interview. Have a good day. Bye-bye.